two, it can help you identify the different signs and symptoms of the different disorders we're going to talk about. Because if you're asking yourself or a patient if they have some, if they do any of these things, then in turn that means if they do, that's a symptom of whatever disorder we're talking about. So it probably will also be beneficial for studying and so forth. So just take a look at that. We're not going to share it in class, but it's just for your benefit. Okay, so okay, sorry. So common sleep disorders include shift work disorder, insomnia, hypersomnia, narcolepsy, restless leg syndrome, and sleep apnea. So shift work disorder. Has anyone ever worked a night shift before? Me, for a long time. And I am one of those people, those 4.5% of people that fell asleep while driving, while working a night shift. And my body does not agree with the night shift. So some people can adapt really well, but I was not one of them. They say that shift work disorder is a circadian rhythm disorder, meaning it goes against what our natural body clock says. So some signs and symptoms are difficulty sleeping, excessive sleepiness, difficulty concentrating, irritability, difficulty with personal relationships. And when we talk about shift work disorder, we're talking about people who are working abnormal shifts. So they're either working at night when everyone else is sleeping, or they're alternating. So maybe 1 week they're working at night, and then the next week they're working during the day. And so they never really get a constant sleep pattern down. 20% of the United States workforce is involved in some type of shift work. And ironically, the most of that work is dangerous work. It's important work. It's firefighters, EMS, nurses, doctors. So safety becomes a real big concern. And some consequences of shift work disorder are increased accidents, work-related errors, increased sick leave, increased irritability or mood problems, increased risk of heart disease, GI illnesses, and drowsy driving. And now, you'll see some of the signs on the interstate that says don't drive drowsy, because they say that 24 hours with no sleep is equal to 0.1 blood alcohol level, which is over the legal limit. So basically driving without sleep is like driving intoxicated. And then like my sleepless first disease, I'm a night shift nurse. Okay, insomnia is the most common sleep complaint. It's the inability to fall asleep or to remain asleep. It can be acute, chronic, or chronic intermittent. And we often have insomnia because of different problems. So much of the same signs and symptoms. Well, we have difficulty falling asleep. So it's like the little gentleman over here counting sheep, and we can't fall asleep. Or we wake up too early. We feel unrefreshed when we wake. Again, difficulty concentrating and irritability. So some things to do for insomnia include, hold on. Well, let's do this first. My slides are out of order. Go ahead, I'm sorry guys. Mrs. Coker is diagnosed with sleep deprivation. You would expect to see. I'm sorry. Maybe I should go stand over there.
What about your camera? Yeah,
Don't. Okay. Okay. Let's see. So, 100%. Awesome. And that's correct. Irritability and diminished control of emotions is one of the signs you would see as sleep deprivation. So, like I said, insomnia can be acute, which means it only lasts a night or two. It can be chronic, which means it persists longer than a month, or it can be chronic intermittent, which means some times you have okay time sleeping and other times you can't fall asleep. And that happens over an extended period of time. So what are we going to do about it? There's a couple things we can do. There's cognitive behavioral therapy, which is just a therapy model that believes that our thoughts create feelings, feelings create behavior, and then behavior reinforces thoughts. So it's all about changing how we think about sleep. We want to have more positive thoughts about sleep and maybe do some really positive rituals, like maybe if we really enjoy yoga or some type of relaxation technique, we want to do that around sleep. So we are thinking more positive about going to sleep instead of always being negative about, oh my goodness, I'm not going to sleep tonight, another night I'm not getting any sleep. It's also important for sleep hygiene, which means, what we've already talked about, setting a routine schedule, not having loud things in the bedroom. We want to have stimulus control, which means we're only sleeping and having sex in the bedroom. So no TV, no movies, just keep the bedroom, no computer. The bedroom is strictly for sleep. Cognitive restriction, we already talked about that. And then again, relaxation therapy. And then our little picture up here, exercise, and make sure it's morning exercise. We don't want to be exercising right before we go to sleep because that's not going to help us. A regular schedule, and we want to avoid smoking and alcohol, and hopefully that's going to promote a good night's rest. So what are some over-the-counter sleep aids? We have melatonin, which one of our friends is taking to help with their sleep. Just so you know, melatonin and valerian root, they're not FDA approved. They're herbs and supplements, so they don't need to be FDA approved. So we just need to be mindful of that when we're providing patient education, because the dosages aren't always the same, and there's not the rigorous research about how they interact with other medicines. So we just want to be mindful of that. Melatonin, the effectiveness is debatable. It helps some people it doesn't. And it works well in shift work disorder, jet lag, and with children with sleep problems. Valerian root is it's a plant-based supplement, but they're not really sure how it works. Then we have our more common medicines. They're sedating antihistamines, so things like Benadryl and Unisom. They were first developed as allergy meds, and then they have their side effect is drowsiness. So now a lot of products that are available over the counter are using them to promote sleep. So things like Advil PM, just the store brand, and Unisom will have them as their active ingredients. One important thing about this is you want to make sure that we're teaching our patients to read labels, because maybe they're having really hard trouble sleeping and they're taking 2 things for sleep that are over the counter. You want to make sure they're not taking 2 things with Benadryl in it. Or maybe they're actually taking something for their allergies. You want to make sure that they're not taking something for their allergies and for sleep, and it's the same active ingredient. So always teach your patients to look at the back of the labels, because there's hundreds of different products out there that say, oh, I can help you sleep better, or this is even with cough and cold medicines. So we want to make sure we're teaching our patients how to read labels. So these are prescription sleep aids. They're called hypnotics, and this is just for your information, but there's non-benzodiazepine hypnotics, which they have less potential for abuse. Varying half-life just means that some get out of your system sooner than others. So maybe the doctor will prescribe one that's longer lasting if their client is having trouble sleeping, through the night. So maybe they're waking up at 2 o'clock and can't get back to sleep. They'll prescribe something that isn't going to get out of their system as fast. And then the benzodiazepine hypnotics can be habit forming. This is the same class as Ativan. So it's going to cause a lot of drowsiness. It can definitely be addictive and habit forming. So they're it's not the best choice to use. And with any hypnotic, we only want to use it for a short-term period, for about 4 weeks is what they suggest. Okay, and here are some nursing diagnoses and interventions for sleep deprivation, and some things we can do to help our clients. So we said, we want to reduce environmental distractions. We want to teach them about stress reduction. So maybe they don't really know how or the importance of relaxation, or they're very high strung. We want to teach them the importance of decreasing their stress and relaxation techniques. Verbalizing their feelings is a good one. If they're having a lot of anxiety about being able to sleep well, just talking to that client about it can help sometimes. That's just there for you guys. Okay, hypersomnia is kind of a little bit of the opposite. It's meaning we're getting adequate sleep, but we're still feeling really tired. So this is idiopathic hypersomnia, which we're just really sleepy and we don't really know why. There's not an obvious cause. It differs from narcolepsy. And symptoms include taking naps, and the naps don't really help you stay awake. Difficulty waking from long sleep, like when they kind of stay in that deep sleep and when you wake them up they're really disoriented or confused. They also have increased sleep times. So they're sleeping a lot, 14 to 18 hours a day, and still feel tired. So things we do for that is giving them stimulant medications and see if there's any lifestyle changes that could be beneficial for them. And narcolepsy is actually a neurological disorder, and it is the inability to regulate your sleep-wake cycles. And you also have an abnormal REM pattern. So again, the client is going to have excessive daytime sleepiness, cataplexy, which is a sudden loss of muscle tone, and it's usually triggered by strong emotions or surprise, laughter, and the patient kind of goes limp. And sometimes the whole body can go limp and they can collapse, but they don't lose consciousness. And that is something that hypersomnias don't have. So that's one of the main differences. They also have hypogenic hallucinations, which are really real-life, dream-like experiences that kind of incorporate your real life into them. Sleep paralysis, which is when you're asleep or falling asleep, you can't move. And disturbed nocturnal sleep, which is when you're sleeping, you keep waking up repeatedly. So it's kind of the opposite of what happens during the day. When you're actually supposed to be sleeping, you're waking up a lot. Treatment, there's no cure for narcolepsy. This is aimed at symptom control and to increase alertness. And one of the things I found interesting in your reading, they use sodium oxybate for narcolepsy as a last line resort to help with the disturbed sleep. And that's actually the date rape drug. I just found that interesting, and it's very well controlled in the United States, but that is something that they do get if it's severe enough. Okay, so these are parasomas and sleep movement disorders. These are things that happen to a person while they're sleeping. It can interfere with your sleep. So bruxism is teeth grinding. Sleep paralysis, we already mentioned, is not being able to move as you're falling asleep. Enuresis is bedwetting. Night terrors is just really terrible dreams. You wake up panicked or screaming because of something that you dreamt about. There's sleepwalking, talking, and eating. And then periodic limb movement disorder, which is where you're moving your legs and arms at night while you're already asleep. But you might wake yourself up because you're moving so much in your sleep. And they classify these based on when they happen in the sleep cycle. And they're really common in children.
How often does one of these have to happen, I guess, before it's considered a disorder?
I mean, I think if it's affecting your life, and some of these might not really cause a problem. A lot of these are safety issues, because if you're sleepwalking, you want to make sure that that person's safe. So, is there a bedroom upstairs and they have to go downstairs? Teeth grinding, it might not cause an issue until you're actually grinding your teeth. So it depends on the severity. The same thing with bedwetting. I mean, that can be a behavioral thing in children. So it's really based on the history that you give, when your doctor is interviewing you. think anytime you talk in your sleep or you're walking in your sleep, that can be considered parasomnia. Question. Okay, so here's restless leg syndrome. So restless leg is different than periodic leg movement disorder because it's while you're falling asleep or at rest. So you have this unpleasant urge to move your legs. You can kind of have like over here, it'll say there's a tingling sensation, you're jittery, you have kind of like that creepy crawling feeling on your legs. They believe it's a neurologic sensory-motor disorder. They don't really know what causes it, but it can have a genetic component because they see it a lot in families. Usually it's more severe at nighttime. It improves in the morning and with movement. So like if you're sitting down for a long period of time, your legs can get really restless. But if you wake up and move, it tends to get better. It affects about 10% of the population, and there's an increased incidence and severity with age. And doctors diagnose this based on history, so there's not a test we can do. It's really just based on history. So I'll give some more nursing diagnoses for that. And the other thing for restless leg syndrome, a lot of times it might be caused by some type of vitamin deficiency or a deficiency in iron, or because of side effects from medications you're taking. So the doctor's going to do a really good history on this patient and make sure that those aren't contributing to the restless leg. Again, relaxation techniques are important. You can give over-the-counter pain relief because it does have some pain associated with it. And also, things like taking hot baths can improve symptoms. Stretching can improve symptoms. Sometimes acupuncture. And another good thing is distraction. So if you're trying to fall asleep and your legs are feeling creepy and you're moving all the time, trying to distract yourself, like engage in activity or a conversation, to try and get your mind off of the fact that your legs won't stop moving can be helpful. Okay. Any questions so far? We're going to talk about sleep apnea. So, sleep apnea. Apnea is defined by having frequent short pauses in breathing that are greater than or over 10 seconds. It can be obstructive, central, or a mixture of both. Obstructive sleep apnea is the most common and it affects a lot of people, 18 million adults. So central apnea, and I'll just touch on this just briefly, is a defect in the respiratory center of the brain. So that can happen if you have any brain damage from an accident or from different neurological disorders like muscular dystrophy. That also happens in infants and children. But we're going to talk about obstructive sleep apnea. Does anyone know anyone with sleep apnea? Yeah, it's very common. So these are the signs and symptoms, and this is just a picture to show you what is actually happening during the apneic events. So there's chronic snoring, sleeplessness, restless sleep, difficulty concentrating, depression. They can have learning and memory difficulties, sexual dysfunction, and falling asleep while at work or while driving. So you can see, it occurs when the muscles in the back of the throat and your tongue fall back into your airway and block that off, which just because you snore doesn't mean you're going to have sleep apnea. Snoring, the same thing is happening, it's just not to the same extent. So, but it's still kind of causing a narrowing in the airway. So this is completely blocking, and you can see where that is. It completely blocks that airway right there. So some risk factors. Obesity is a big risk factor. If you're born with a smaller upper airway, if you have a large tongue, large tonsils, or uvula or adenoids, if you have a larger neck, like a larger neck diameter, if you have a recessed chin, so your chin's back further, smoking and alcohol use can be a risk factor, and also the older you are, the more at risk you are for sleep apnea. Okay, so there are tons of health consequences for untreated sleep apnea. So I've listed them here. First would be oxygen deprivation. Well, while these patients are having their apneic episodes, they're lacking oxygen. So that can lead to stroke, it leads to hypertension, cardiac arrhythmias. So there are tons of things that can happen if we're not treating sleep apnea. So it's one of the more serious health concerns. And then I put this up too, I found this online. Just for you guys, it kind of tells you people that have obstructive sleep apnea and the percentage that they're going to have these associated problems if it doesn't get fixed. So you can see it affects everything from, the top, your brain, all the way down. And it's expensive too. People can have sudden death, so it's pretty serious. Let's see if there's anything else I want to. Daytime sleepiness, hypertension, and congestive heart failure are also really big side effects of not getting this treated. So that's just for you guys to kind of look at and review and understand that if you have a patient that has sleep apnea and is being non-compliant with their treatment, how important it is to kind of help them be compliant. Okay, these are some studies that we do to diagnose different sleep problems, and really, sleep apnea is really the only one that can be diagnosed with these, but oftentimes if you come in with a sleep problem, they will put you through a sleep study just to make sure you don't have sleep apnea. And during the sleep study, you're going to have an EEG, which is looking at your brain activity. You're going to have an EMG, which is looking at your muscle tone. And you're going to have an EOG, which is looking at your eye movements. They take place outside the home. You're hooked up to all these wires. It's usually uncomfortable. But that's really how sleep apnea is diagnosed. There is this newer thing,
Actigraphy?
Yes, Actigraphy, which is a sleep monitor that is worn on your wrist. So it records movement while you're sleeping, and it kind of can estimate your sleep parameters and your sleep cycle based on how you move during the night. And one of the benefits of this is that it occurs in your natural sleep environment. So it can be really helpful for some of the other sleep disorders too, but they still want a sleep study done if they're worried about sleep apnea. Does anyone, I was trying to find out more information, has anyone seen those sleep monitors like in health and food stores? No? They make them now, like how you can have a pedometer to trace your steps and everything. They make one now for sleep monitoring. And supposedly you can put it on and it tells you how long you slept and the quality of your sleep. So I think it's using that technology to do that. But yeah, you can get them. I saw it at Walmart the other day when I was in the exercise aisle. So that was really interesting. Okay. So what do we do for obstructive sleep apnea? CPAP is the first line standard, and that's this picture over here. It stands for continuous positive airway pressure. We can also encourage our patients to lose weight, since a lot of people with sleep apnea are overweight. We have dental and oral appliances that can kind of keep that airway open while you're sleeping. And then also we can do surgery to remove any excess tissues, which is that's what that is showing down there. And usually you got to be careful with some surgeries because they were saying if you take away the cause of snoring, a lot of times you take away the alarm that someone's having obstructive sleep apnea. So instead of, it takes away the warning signal. So usually surgery isn't the first line of treatment. I mean, it is for kids, but that's a different ballgame. Okay, so how does this CPAP work? Sorry, my picture's a little fuzzy. So here we have kind of the same picture from before, but when we put this mask on, it's blowing air into our nose and mouth and causing high pressure. So it's keeping the back of our airway open. So instead of these tissues and our tongue falling back, this air that's being pushed into our lungs helps keep it open. And it can be used with or without oxygen. Some people need to have oxygen along with their CPAP. But a lot of people are non-compliant. because it's uncomfortable. I think now the machines aren't as noisy as when they were first developed, but a lot of people don't like to use their CPAP. So it's really important if your patient comes in and has a history of sleep apnea that you make sure that they have their machine with them and that they're using it and that they know how to use it. Okay, let's do a question. The client is being treated with a nasal continuous positive airway pressure device, CPAP, for sleep apnea. What finding would the nurse evaluate as indicating that this treatment has been helpful for the client? Okay, does it say 8 or 9? 8. Okay, we'll go ahead. There we go. So number 4, the client reports a decrease in morning headache. Now, I can't see the percentage, but it was a good amount. That's correct. So why would we see a decrease in the morning headache if they're using their CPAP? Why is the patient having a headache if he has sleep apnea? Let's start with that. Yes, yeah, because they're having some oxygen deprivation, so that's why we're waking up with a headache, because we're being not supplied with oxygen efficiently. So yeah, great job. Okay, so here are some nursing diagnosis and interventions for sleep apnea. The 2 main differences I want you guys to focus on is ineffective airway clearance, because their airways being cut off by those tissues in their tongue. And then also impaired gastric shift, because while that's happening, their oxygen saturations are going down. So as opposed to the other sleep problems we discussed, these have an airway component which make them priority for these patients. And then also I put deficit knowledge on here because a lot of patients probably don't understand the risks of not treating their sleep apnea and how many comorbidities can happen if they're not getting treatment. So we want to make sure we're correcting, ensure the correct use of the CPAP machine, provide education about the side effects and the use of the CPAP machine, and monitor oxygen levels. Here are some of the sleep centers around. And with all the sleep disorders and problems, our goal is to maintain or develop a sleep pattern that provides significant rest and energy for our clients. And these are some of the local sleep centers. That's all they do is talk to patients about sleep and try and figure out, how to best treat their sleeping problems. Okay, what are some things, before I go to the next slide, that you guys think about that we can do in the hospital for our patients as far as helping promote sleep?
Limit the amount of time that you have to go into the room.
Yeah, definitely. So that's called clustering care. We want to make sure that we're performing activities together. So we want to collaborate with our care partners or our nursing techs, whoever's there to help us with vital signs, that we're doing stuff together. We also want to make sure that we try and avoid really noisy things at night. We can make sure that our IV pumps aren't going off in the middle of the night and waking up our clients. So we also want to decrease sound and decrease light. Some hospitals are actually implementing quiet hours, where the staff and the other patients have to have TVs turned off and everything like that, kind of like when you went to camp as a kid and you had quiet hours. You want to make sure we're lowering outside noises. I know when I worked the night shift, we weren't always so good at that. We kind of talked loudly at the nurse's station, and we forget that our voices travel and probably disrupting our patient's sleep. And we want to close the patient's door if we're able to. So so the sound doesn't travel as much. Decreased light can sometimes be a problem. I know in my hospital we don't have curtains, so when the sun is shining at 6 o'clock in the morning, oftentimes our parents are up and awake because it's blinding their eyes. But if you can, and your hospital has curtains, it's important to use them. Also, using flashlights or pen lights when you're going in at nighttime instead of flipping on all the lights is helpful. And turning off hallway lights if able to, and then of course classroom care. Do you have any questions? Yes.
Say one thing, that's not a question, but when I worked pediatrics, we weighed our patients every morning at 4, especially our cardiac kids, and then we really began to advocate for the patients. They just wanted it at the same time every day.
Yeah.
And so we advocated doing that to a different time, but we really had to push the surgeons because they wanted it. So when they got there, it was on the chart and it was ready, but the parents complained about it so much because their kids were so sick.
Yeah.
So we ended up getting that changed.
So we currently weigh infants like 12 years and less before 6 o'clock.
12 months.
12 months, I say 12 years. What did I say?
Years.
Sorry.
12 months, that's fine.
And we try and coordinate with the feeding, because normally, they tend to be up earlier, so we try and coordinate that. But kids that are older will wait till everyone's up. But it's the same thing. We just have to do a really good job at talking with our families before they go to sleep about when's the best time to wake them up. Okay, you want to do that case study? Or?
So one more question?
No, I'm here.
Oh yes, I'm sorry.
That's okay.
I had my thing flipped over. Yes, final question. When a hospitalized patient tells you she cannot sleep, it would be appropriate to ask what she does to promote sleep at home. All right, we have about 15 minutes. So do you think we have time for the case study, or do you want to do the? Yeah. Okay. Any last questions?
I have the test folders, so we'll do that. Let's say thank you.